on the current concepts in the neuraxial techniques in the neonates. I usually do only neonatal thoracotomies. I don't do anything else apart from in the pediatric practice. The limitations of the neonatal neuraxis is small epidural space, which is less than 2 millimeters. Trauma to the spinal cord, threading catheters, malfunctioning of the epidural catheters, or malpositioning rather. Placing the catheter tip at the desired nerve root level is the most important thing in all the thoracotomies. If they go on to at the T2, T3 level, it means that the tip of the catheter has to be very close to that particular level. Now this is a video clip which shows a single short caudal which we usually use in all our laparotomies, and you can see the delayed awakening which was caused because of very high spread of the caudal epidural. And there is at the point of the scapula, the spine of the scapula, and then at this point the neonate, after you pinch him, he awakens. It means that a single short caudal of around 2.5 ml that we give in a neonate can spread very high in the epidural space. There have been malposition of the catheters, like what they are mentioned here in this literature, where there is a paravertebral spread and unusual placements of the catheter in the peritoneum and in the sacral areas. So what happens when you do unmonitored neonatal epidural catheterization? You can see that this is the MRI of the neonate epidural space. It's a straight line, and this is the advantage of the epidural space in the neonates, where we catheterize and it goes right up to the cervical area. But as you advance the catheter, there are chances of intravenous cannulation, as you can see here, knotting of the epidural catheter, no damage, and there can be a unilateral sensory analgesia. So you have to verify the tip of the epidural catheter, and this can be verified by injecting a contrast, which is very difficult in the pediatric setup. It's okay in the orthopedic setup. You have nerve stimulation by the band sweep test and the ultrasound, which can again help in localizing the tip of the epidural catheter. You need to precisely place the catheter because the thoracotomy requires a level at around T3 to T4, and the others require a level of at around T7 to T8 to have a precise pain relief in the perioperative period. So the focus is on the caudal catheters, which is done either by neurostimulation or it's done by the ultrasound technique. So let us see how we do it by epidural neurostimulation. Now the definition is you stimulate the spinal nerve roots with a low electric current, and this is by electric conducting catheter. You saw the catheter, the stimulating catheter. So same stimulating catheters can be used for the epidural space. Now this is a tracheoesophageal fistula, a thoracotomy, where you place in the catheter. You know how much the length of the catheter has to be placed. It has to be light planes of anesthesia without any muscle relaxants. It can be light using a volatile anesthetics. You can see the contractions over here. There was a plantar flexion, now there is a dorsiflexion, and as you move higher up, you have some contractions of the hip, and then ultimately you can see the contractions of the arm, so that the epidural space has gone very high up in the cervical area, almost to the cervical area, and now it is initiating the stimulation of the brachial plexus. Once you start withdrawing the catheter, you can see there is contractions of the hand. At this level, it means it is at the level of C8T1. You have to again withdraw the catheter, so that you can see now that the contractions in the area of these thoracic dermatomes, where exactly your catheter has to be. You inject your local anesthetic, you get a good block, and then you can do it under light planes of general anesthesia. So you need to have a stimulating catheter for this to precisely place the tip of the catheter at around the level of T3 and T4, and you start stimulating from downwards up. At this point, when you are stimulating at this point, the electrode has to be here. When you are stimulating at this point, the electrode has to be in this at the level of the hip joint. So that is how you place the stimulating catheters, and this is where you subcutaneous tunnel the catheter. So it is safe. Is it safe? The stimulating the epidural space, is it safe? Say brief muscle contractions with a maximum current of less than 15 milliamperes is allowed to stimulate the epidural space even in the neonates. Now what is the outcome? There is a decreased prolonged postoperative ventilation of abdominal and thoracic procedures. Now what I do is that when I inject my local anesthetic in the epidural space, I get a good block. Once you get a good